want to start just by kind of telling you a little bit about my story, not really to talk about me, but just so you know how I got here and where I'm coming from in presenting this information. I was diagnosed with idiopathic gastroparesis in 2004. It's about 9 years ago when I was 23, and I assume most of the gastroparesis in this room is secondary to the mitochondrial disease, but in my case, they just don't know the cause. It's not secondary to any kind of medical condition. And when I was diagnosed, I had no clue what it was, I think like most people, and so I did what I think most people do, is I Googled it. And 9 years ago, there really wasn't a lot of info about gastroparesis on the internet. So what I did find were a few message boards that were really super scary and frightening. And it seemed like my only choice was either to just be resigned to the fact that there was nothing I could do and eventually end up on a feeding tube and whatever, or to search for some elusive expert or magic cure that would just rid me of all of my problems. So I opted for the latter and kind of went on a frantic search for about 5 years. And 5 years later, I was no better off. I was sicker than ever, lost 50 pounds, I was malnourished, in a ton of debt from all the medical bills, just depressed, anxious, no job. And that's when I realized that I'd kind of have to find the answers for myself. So I enrolled at the Institute for Integrative Nutrition and studied holistic health. It was also a health coaching program, but I had no intention of coaching other people. It was just for me, so that I could figure out how to return some normalcy to my own life. Around the same time, I had the Gastric Neurostimulator implanted, and between that and the work that I did at school and the things that I learned, things really began to turn around, and I started blogging about it, and then people started wanting me to coach them. So I did. And now, several years after that, I've coached hundreds of people with gastroparesis. I've written 2 books, I've run programs, and what I've learned through all of the people I've worked with and through my own experience is that the comprehensive management plan that I'm going to talk about tonight can make a world of difference in the way somebody can live with gastroparesis, the way you can manage your symptoms, even in the context, I think, of secondary, being secondary to a larger condition. So that's really what I want to talk about tonight, is a comprehensive management plan. But in order to do that, I think we have to make sure that we have a good understanding of gastroparesis. So that's where I want to start. I'm going to use the first part of this just to explain gastroparesis, and then we'll talk about the management plan. And I kind of set this up as like true or false questions, so I don't know if anybody feels like yelling out an answer, they can. Otherwise, I'll just tell you the answer. The first thing is that true or false, having gastroparesis means that your stomach is paralyzed.
False.
False.
Excellent. False. So gastroparesis, literally translated, would mean something like stomach paralysis, but it's actually a misnomer. So I think we have a doctor in the room. Is that what I remember from the email now? Okay, I was like, that's why he's so much conviction about this. It's a bit of a misnomer. It's more of delayed gastric emptying. So the stomach empties slowly, as opposed to being completely paralyzed. It's very rare that the stomach is completely paralyzed. So gastroparesis is delayed gastric emptying. It affects the stomach. There are motility disorders that affect other parts of the GI tract, but a gastroparesis diagnosis is specific to the stomach. It is a functional disorder, so it's part of a group of disorders called functional gastrointestinal motility disorders, FGIMD. And basically that means there's no physical obstruction, there's no physical abnormality of the stomach itself. So if you were to look at it, you wouldn't necessarily see gastroparesis. It's in the way that the stomach functions, either because of the nerves or the muscles or an underlying condition. Okay, true or false? Gastroparesis is a rare condition.
False.
False. The estimates vary. There aren't a lot of great statistics about gastroparesis, but it varies from 1 million people up to 8 million people. The one that I think is most agreed upon is about 5 million Americans who have gastroparesis. So it's not nearly as rare as most of us think, despite the fact that it's poorly understood and there is a lack of awareness among the general population, and I think among parts of the medical community as well. But it's not nearly as rare as we might think. There are more people diagnosed with gastroparesis than celiac disease, for example. True or false, gastroparesis is diagnosed via endoscopy?
False.
False. Certainly an endoscopy can give your practitioner an idea that gastroparesis may be present. As Jane was saying, if you have an endoscopy and you fasted for 12 hours and they find food in the stomach, that's usually a red flag to send you for the test that actually diagnoses gastroparesis, which is a 4-hour gastric emptying scan. Now, some places do 90-minute scans, 2-hour scans, but 4 hours is really kind of the gold standard. Because you can have regular emptying at 90 minutes or 2 hours and have irregular or delayed emptying at 4 hours. So it misses some diagnosis when you don't do the full 4-hour test. The test is the best test that we have, I think, for diagnosing gastroparesis, but it's not perfect, and part of that is because it's not standardized, which may seem surprising, but different medical centers perform it differently. Not just in the time frame, but some places will give you an eggs and toast meal to eat, some will give you oatmeal, some will give you soup or stew. And I think most of us who are familiar with at least the basics of gastroparesis know that what you eat affects the emptying time. Also, some places will have you lie flat for the entire length of the scan, and other places will have you get up and go sit in the waiting room. And so part of gastric emptying is gravity. So if you lie flat, you're going to empty more slowly. So because it's not standardized, that can make it difficult if you go to different doctors for them to interpret the results. You may have to repeat tests. It can make it difficult to monitor over time. So it's not a perfect test, but that is how gastroparesis is best diagnosed, is through a 4-hour gastric emptying study. All right, true or false? Gastroparesis always causes vomiting.
False.
Right, you guys are catching on that these are all false. So it does not always cause vomiting. I get a lot of emails from people, and a surprising number of them are from people who say, I was diagnosed with gastroparesis, but I never throw up, so I don't think this can be correct. Similarly, I get a lot of emails from people saying my main symptom is pain, and so I don't think that can be correct. And the experience of gastroparesis, the way people experience the symptoms, varies drastically. I've seen people with all kinds of combinations of these particular symptoms. So the symptoms can include nausea, vomiting, fullness after eating, which we call early satiety, bloating or distension, so the feeling of being bloated or the actual visible distension of the belly, sometimes as much as looking like you're 6 months pregnant, reflux or regurgitation, and also abdominal or even non-cardiac chest pain can sometimes be symptoms of gastroparesis. And so people don't necessarily have all of these. You can have any combination. There are people who may have primarily the abdominal pain and people who may have primarily the fullness without really any other GI symptoms. So they present differently, and that's why it's important to get that diagnosis, to get that confirmation of the delayed gastric emptying. There is a similar condition called functional dyspepsia, which is basically gastroparesis-like symptoms in the absence of an actual delay. And medically speaking, they're treated differently because you wouldn't necessarily use some of the medications that we're going to talk about if somebody doesn't have the delay in gastric emptying. But the rest of the comprehensive management plan that we're going to talk about in the second part of this program works for both, for functional dyspepsia and for gastroparesis, also for other kinds of functional GI disorders like IBS. So I know we had a little bit of talk of people who feel like they have gastroparesis, but on testing do not. That'll probably still be helpful for you. All right, so I guess we don't need to do true or false. You guys know they're all false. The next one is gastroparesis is most often caused by diabetes, and that's false. I think that's a common thing that people, even people in the medical community, when I used to go to the ER a lot for the gastroparesis, everyone would automatically assume I was diabetic. The most common classification of gastroparesis is idiopathic, so no known cause. Obviously there is one, just don't know what it is. Diabetes is the most common known cause. It used to be just not just, but mostly type 1, because it takes a long time for the damage to occur. But now that people are being diagnosed with type 2 diabetes earlier and living longer with it, it's becoming more common among people with type 2 as well. Viruses, parasites, bacteria, abdominal surgeries can cause gastroparesis, and of course underlying medical conditions. So certainly things like mitochondrial disease, other kinds of things like Parkinson's and scleroderma, dysautonomia, POTS, a significant portion of people with gastroparesis who have it secondary to a medical condition. And of course that makes management that much more difficult because then you're managing it in the context, right, of a larger condition, which I'm sure you guys can really relate to. gastroparesis is easily treated with medication. False. Medication does not work for everybody with gastroparesis, and even if it does work, it doesn't usually completely eliminate symptoms or eliminate them to the extent that that's all you have to do, is just take a pill and you'll feel better. They also, most of them carry a risk of side effects, some potentially quite dangerous side effects. So there are kind of 3 classifications of medication that are most often used for gastroparesis. The first is a prokinetic drug, which prokinetic means it actually encourages the stomach to move, to contract and empty the food. And so these are drugs like Reglan and erythromycin, both of which are approved for use in the United States for gastroparesis. Reglan has a black box warning for its potential for cause tardive dyskinesia, a potentially permanent neurological side effect. So it's a judgment call. You know, a lot of people use it anyway and find that it works. Some people aren't comfortable with that, but obviously it's not ideal. Erythromycin you may know of as an antibiotic. It's used at low doses for gastroparesis to stimulate the motility of the GI tract. The problem with erythromycin is after a while the efficacy wears off, so you have to kind of cycle on and cycle off or use it only during flare-ups. Also, for some people, it exacerbates GI symptoms, makes nausea and stomach pain worse. So neither of those are ideal, but both of them do work for many people, and they work well. Domperidone is another drug that you may have heard of in relation to gastroparesis. It's not approved for use in the United States, but it is available in most other parts of the world. And many doctors in the U.S. will write a prescription for it, and you can obtain it from pharmacies in Canada or New Zealand. You can sometimes have it compounded at a compounding pharmacy in the United States. And again, it's not without its risks. It does carry a risk of certain cardiac side effects. So people with cardiac conditions need to be careful and talk with their doctors. But those are the 3 prokinetic medications that are typically used to stimulate the actual motility of the stomach, to actually encourage it to empty its contents. Antiemetic medications are another common way to treat gastroparesis. It's not treating the underlying condition, but it's helping to alleviate the symptoms of nausea and vomiting. So these are things like Zofran, Compazine, Phenergan. Again, not without side effects and a little bit of a catch-22. Some of these actually increase constipation and motility problems in the lower part of the GI tract, which is the same for pain medication, which is another group of drugs that are sometimes used for people with GP if the pain is quite bad. But narcotic pain meds make constipation worse, and then that actually affects your gastric emptying, and it slows down the upper GI tract. So it's kind of a catch-22. My motility doctor told me about a study that they did with med students, and they checked their gastric emptying and took a group of students with normal gastric emptying, intentionally constipated them for a certain period of time, rechecked their gastric emptying, and many of them had delayed gastric emptying. So we know that constipation affects our gastroparesis, and that's something that we need to really pay attention to, especially when you're taking medications that can cause constipation, or if that's kind of another issue secondary to medical conditions. True or false, gastroparesis can be fixed with surgery. This is largely false. There are a few different kinds of surgical procedures that are done for people with gastroparesis. There are something called pyloric Botox injections. These are kind of falling out of favor. For a while they were being recommended, but it's about 50-50, I think, at this point as to whether or not they actually help people. Some people do notice great relief from them, some people notice nothing, and if you do get relief, it lasts usually between 3 and 6 months. And this is where they actually inject Botox into the pylorus, which is the sphincter between the stomach and the duodenum, the first part of the small intestine.
Sorry.
No, it's okay. That's okay. So that it opens that sphincter, and gravity alone helps to increase your gastric emptying time. Many doctors won't do this anymore. Many insurance companies won't fund it because there's just not a great deal of evidence that it's actually effective. The Gastric Neurostimulator, which I mentioned, I have this. I had it implanted in 2009 and again in 2010. Mine broke. It's also called the Intera device, and this works only as a symptom management tool. It doesn't actually increase the gastric emptying of the stomach, but it does work on the nerves that go from the stomach to the brain that send the signals of nausea and vomiting. So in about 70% of people, it provides symptomatic relief. There's not really a great way of knowing who those 70% are versus the 30% who won't respond. And of course, surgery, all kinds of surgery, and having a device implanted carries risks of its own. So, but for many people, it's quite effective. For me, it was definitely part of my turnaround with gastroparesis. I think in the absence of the rest of the things that we're going to talk about, it wouldn't have been nearly as effective. But as part of a comprehensive management plan, it's been quite effective for me. There can also be feeding tubes surgically put into both the stomach and the small intestine, either for venting of the stomach, a G tube, or for actual nutrition of the J tube. I think the picture, especially online, is skewed a little bit. That makes it seem like feeding tubes and artificial nutrition are more common among people with gastroparesis. Again, there's not a great amount of data, but from the studies that I've read and the information that I've read, it seems to be about 15% of people with gastroparesis who require artificial nutrition, whether G-tube, J-tube, TPN. So that's just something I like to put out there because I think a lot of times that's a big fear for people, and I think it's less common than it sometimes looks online. There's something in the pipeline, and this isn't necessarily surgical, but it's done via endoscopy. At Johns Hopkins, they are doing a transpyloric stent. So they are putting a stent in the pylorus to keep it open and encourage gastric emptying. And they've done a very, very small study. I think there were only 3 people in it. But they had good success with those 3 people. So they put out a press release and they're excited about it. But obviously we need a lot more research and information. But that is something in the pipeline, and I think that's important, though, just to know that there are things in the pipeline. There are things being researched and worked on. All right, true or false? Gastroparesis is a progressive condition that never gets better and never goes away. It's a little bit of a trick question because the progressive nature kind of depends on the underlying cause. But it can get better and it can go away. Again, most of this depends on the cause. So gastroparesis itself, it's like gastric emptying, is not progressive. It's not necessarily progressive. It can even improve over time. Gastric emptying can normalize over time. It can improve over time. There is no medical cure for gastroparesis, but for some people it does indeed go away, and many people actually get better. If there is a progressive underlying condition, that obviously affects the gastroparesis as well. But there are people who get better, and symptoms can definitely get better and definitely improve with the comprehensive management plan, regardless of underlying cause. All right, and last one, gastroparesis is best managed with dietary changes and or medication. So traditional gastroparesis management is kind of this 2-pronged approach: a low-fat, low-fiber diet and medication, or surgery or some kind of medical intervention. For most people, I have found in my own coaching practice, and certainly personally, and just with the people I've talked to, that's not terribly effective. It may help to eliminate symptoms, but most people are still struggling with a lack of normalcy in their life. Most people are still struggling with daily symptoms to some extent. So what I've found to be most effective is a multi-pronged approach. And we're going to go through actually 8 things tonight that we can do to help to minimize symptoms and improve the quality of life in the context of gastroparesis. And that's what we call a comprehensive management plan. So you've heard me say that a few times tonight. So that's what we're going to talk about for the rest of the time. So a comprehensive management plan, as I said, it's multifaceted. It also needs to be dynamic. So just to keep that in mind, that your needs may not always be the same. So as we go through and talk about this, some of it may not resonate for you right now, but there may be a time where that becomes more important to you. Also, like I said, it's individualized. So it may not apply to everybody here. Every piece probably won't apply to everybody here. But you take what works for you. And there's a lot of experimentation and trial and error within that. So the first part of the comprehensive management plan is obviously appropriate medical treatment, which we've already talked about. And that varies from person to person. I use the word appropriate very deliberately, because what's appropriate for one person is not going to necessarily be appropriate for anyone else. A gastroparesis diagnosis says nothing of severity. So you can have a gastric emptying scan and have 11% of your meal remaining at 4 hours and be diagnosed with gastroparesis. And someone else can have 92% of their meal remaining and be diagnosed with gastroparesis. So medical treatment for those two people are going to be very different. What's appropriate for one is not appropriate for the other. So appropriate medical treatment is obviously an important part. Not everybody needs medication. There are a lot of people who are not on medication. I'm actually not. I was, but I'm not anymore. I do have the neurostimulator, so that's the appropriate treatment for me. Obviously, within this, it's important to have good doctors that you trust, doctors that are knowledgeable, that are allowing you to be, an active participant in your healthcare. And I call that a dream team, developing your dream team of practitioners. And so that's part of your appropriate medical treatment piece of the gastroparesis management plan. The second part is stress management and purposeful relaxation. And this actually comes, I put it right at the beginning, because I find that it affects every other part of the management plan. So from here on out, everything else is pretty much about self-care. It's about things we can do for ourselves. Our doctors do what they can do, then we have the responsibility to take care of ourselves as well. And stress management can really affect all of our other efforts. And so we can be doing every other piece and still dealing with symptoms if we don't address this. And that's because you probably heard the fight or flight response. When our body is stressed out, it goes into what's called the fight or flight response, also known as the stress response. And when it does that, it releases stress hormones, and that actually impacts our digestion. When your body's in fight or flight, it basically shuts down anything that's not necessary for immediate survival, which includes digestion. You don't need to digest your breakfast if you're running for your life. It also shuts down its repair mechanisms. So when you're constantly in these stress responses, your body is not digesting properly anyway, even if you were able to digest properly, and it can't repair anything that's gone wrong. And I just read an article that said the average person has 50 of these stress responses a day, and I'm willing to bet that people with gastroparesis and people with other medical conditions are having many, many more because of the stress of living with those conditions and managing those conditions and feeling those physical symptoms. So if you think about it, minimum 50 times a day, your body's going into this fight or flight mode and shutting off digestion and shutting off repair, you can see how that might impact all of your other efforts at management. So the opposite of fight or flight is called rest and digest. And that's when your parasympathetic nervous system is in control, basically, and that's where your body's digesting properly, it can repair. To get into that state, to basically turn off your stress responses, there's a practice called the relaxation response. And there's a book by Dr. Herbert Benson. He was from Harvard, and he came up with this exercise that actually shuts off the stress response, puts you back in this rest and digest mode. There's a whole book about it. It's a really short book. It's like $5 on Amazon. Basically, you sit for 10 to 20 minutes. You don't even have to close your eyes. You can really do it anywhere, and you just focus on your breath. And you pick a word or a phrase that means something to you. Love, peace, one, a prayer, whatever. And you just focus on that word with each exhale. And as thoughts come into your mind, you just kind of let them go. You don't fixate on them. You don't get a story about them. You don't start like beating yourself up because you're not doing it right. You just really come back to that word. And you do this for 10 or 20 minutes, and it puts your body back into this rest and digest state. And so this can be a really important part of a management plan, especially if you're somebody like me who's kind of in that stress response more often than not.
Crystal, do you do that after is it more effective to do it right after you eat or any time in the day?
You can do it any time during the day.
There's not an effective time to do it?
Not that I know of. Not that I know of. I don't know of any particular time being more effective. They say to do it 10 to 20 minutes once or twice a day. So I would say if you're not doing it at all, probably start with like once, 10 minutes, 10 minutes once a day, and then build up. Yeah, but at any time, certainly. All right, and so the next part is supportive lifestyle practices. And so there are a number of these, but the two most important ones are really physical activity and sleep. And again, this is where, like I said, not everything may be applicable to everybody, especially in this room, so you pick and choose what's going to work for you. But physical activity can be really beneficial for gastroparesis. Mild to moderate physical activity actually enhances gastric emptying, and it can alleviate bloating and fullness and other symptoms. strenuous physical activity can actually decrease gastric emptying or increase your gastric emptying time, I guess. You'll slow your stomach down. That's the easiest way to put it. But regular mild to moderate exercise is, for many people, a really important part of a management plan. Sleep is the other one. Our digestion takes a great deal of energy. So if you are sleep deprived, your body has less energy to devote to that overall. You're also less likely to do all of these other things that we're talking about because you're just exhausted. I can say personally, I had a baby a year ago. So obviously there are many things that are different, hormones and everything, but sleep in particular, I've noticed a drastic difference in my ability to manage my symptoms before I had the baby, when I was sleeping 8 hours a night, and in the past year when we've been lucky to get like 5 hours a night. So that's important. And obviously, sleep hygiene and good bedtime routines can help with that, but that's something that may need to be addressed separately if that's a big issue. And again, that's something that you may need to discuss also with your doctor if it becomes a significant issue where you're dealing with a lot of insomnia. Just a note, to avoid alcohol and cigarettes, both of those slow your stomach emptying. So I think I read that that's also important for mitochondrial disease, and obviously just for overall health, especially smoking. But it's not good for the GI tract and in particular for gastric emptying. All right, so those are just a few of the lifestyle practices. There are many, but those are, I think, some of the most. The next piece is dietary modification. And this is smaller, more frequent meals. This is, I think, something that most people with gastroparesis are familiar with. At least, most people at least get a one-page handout from their doctor that says, low fat, low fiber, small meals. Unfortunately, that one-page handout often has things like white bread and, white sugary cereals and skim milk and not a ton of nutrition, which we're going to talk about in just a minute. But the point is for it to be lower fat. Most people do well with between 25 and 45, 50 grams of fat a day. Lower fiber, usually between 10 and 15 grams of fiber a day. And reducing hard to digest foods, anything with a skin, peel, nuts, seeds, things like broccoli and popcorn, things that just, when you think about them, you can picture you not being able to chew them completely, them being very fibrous or hard to digest. Again, much more information in the Quick Start Guide, and I wrote a whole book on the diet, so there's a lot about that. But how we eat, I think, is something that we don't necessarily think of, and I wanted to touch on that because I think in many ways that's equally important to what we eat. So eating slowly and calmly and in a relaxed environment. We just talked about the stress response and what that does to digestion. So if we're really stressed out, anxious when we're eating, whether about something else or about the food, with gastroparesis, sometimes eating itself makes us really anxious. Then it's kind of a catch-22 because when you get anxious and your body pumps out these stress hormones, it shuts down your digestion. So then you're more likely to have symptoms, and then you become more anxious about eating the next time. So just being really mindful of that, and maybe taking a few deep breaths, whether you actually do the relaxation response exercise or not, but at least taking a few deep breaths and trying to avoid eating if you're really worked up. And chewing. Chewing is really important because the part of the stomach's job, the stomach has a few jobs, part of it is to grind our food up into particles small enough to be emptied from the stomach into the small intestine. And if our stomach isn't working effectively, we really need to give it some help by chewing as completely as possible. The same reason why sometimes pureed foods work better, because they're completely ground up, and we can do that quite effectively with our mouths if we chew. Most of us do not chew nearly as much as we should. So that's important. And also when you start chewing, there are enzymes in your saliva that start to break down the food in your mouth, especially carbohydrates. And it also signals to the stomach to get ready for food, to prime itself for digestion, release acids and whatever else, juices, whatever it releases. So if we don't chew properly, we're kind of starting at a disadvantage before the food even gets to the stomach. So that's an important point that I just wanted to point out in terms of diet. The next thing is proper nutrition and usually supplementation. As I said, a typical gastroparesis-friendly diet tends to be white, packaged, processed, not very healthy, not very nutritious. And as you can see as we go through this, we actually have a lot of tools to help manage our symptoms, but really our only tool for our nutrition is our diet. So I really encourage people with GP to think about maximizing the nutrition in everything they eat and drink, because for most of us, our actual volume of food is limited by the feelings of fullness, the vomiting, the nausea, whatever the other symptoms are. So you really have to get the most bang for your buck and really think about that and avoid as much as possible those empty foods that fill you up but offer really nothing in the way of nutrition. It's my opinion that some of what looks like a progression of gastroparesis or just additional symptoms, it might seem like just getting one thing after the other, can be due to malnutrition or deficiencies in vitamins and minerals, fatty acid deficiencies, things that we might not think of, things that we might not necessarily be tested for, but that can cause subsequent symptoms. So the way that I encourage, the easiest way I think to start maximizing the nutrition is to think about eating a rainbow of foods, a GP-friendly rainbow. So that means whether over the course of a day or a week, wherever you're coming from, you think about getting foods in every color of the rainbow, GP-friendly versions, and or prepared in GP-friendly ways. So juicing can be really helpful for this, smoothies, purees. There's more information about this as well in the Quick Start Guide, but that's just kind of an easy visual for thinking about ways to start increasing the nutrition in your diet, because that's really where our nutrition comes from, in large part, is from our fruits and vegetables and the various colors that they offer. Supplementation. Many, if not most people with gastroparesis will benefit from some kind of supplementation. It's really hard to get all of your adequate nutrition from a limited diet. And there are certain vitamins and minerals that are actually really important for digestion and can then impact our ability to digest food if we start becoming deficient in them. Things like B12, magnesium, even vitamin D. And these are things that are really common to be deficient in, especially B12 and also iron. If you're on proton pump inhibitors, many people with gastroparesis are put on medication for acid reflux disease, things like Nexium and Prilosec. Those can impair your ability to absorb B vitamins and iron. So these are things we want to be aware of. The next thing is complementary therapies. And so there are a whole bunch of complementary and alternative therapies, but there are a few that have been particularly found to be beneficial for gastroparesis symptoms. Acupuncture has actually been found to be pretty effective for nausea and vomiting in particular. Also for insomnia. So if the sleep is an issue, acupuncture can help. Also for depression and anxiety. So a lot of the things that many of us with gastroparesis struggle with can be helped by acupuncture. Hypnotherapy has actually been proven in studies to be as effective as medical treatment for abdominal pain, functional abdominal pain. So things like with functional disorders like gastroparesis, and this is particularly true in children. Hypnotherapy can be extremely effective. When we're talking about the stress response, massage therapy dramatically and immediately lowers cortisol, which is our main stress hormone. So if you're having a lot of trouble getting out of the stress response, regular massage can actually physically relax your body and decrease your levels of stress hormones. It is important whenever we're talking about any kind of complementary therapy that you obviously find a knowledgeable and qualified practitioner. You may also have to try multiple practitioners. Just like doctors, not everybody is the right fit for everybody. So it's important that maybe if you really want to try acupuncture and you try one practitioner and you don't have a great response, you try one more maybe just to see. I've been to 3 different acupuncturists and I've had very different responses with all of them. So there are also some herbal remedies that you can use for gastroparesis, but again, you always want to check with your doctor because some of these things can interfere with medication. They can be contraindicated for certain conditions. And things like ginger has actually been shown to be just as effective as Reglan for motility, for improving motility. But you have to take it at really high doses, about 1,000 to 1,200 milligrams a day. And at that level, it has blood thinning properties, so that's why you want to talk with your doctor if you're on blood thinning medication or you have any bleeding disorders. But they have found in studies that it can be taken in doses of about 400 milligrams 3 times a day, and when taken regularly, it has the same kind of effect as Reglan. Iberogast is another herbal supplement. It's a combination of herbs. It's been used over in Germany and the UK for decades, and is now becoming more and more popular in the United States. And they have some studies that actually show that that improves gastric emptying as well. So there are some other options that you can try, again, talking with your doctor and taking into consideration what works best for you.
What was that last name?
Iberogast, Iberogast. And they have a website. You can get it on Amazon even now. They sell it. There's a review on my website about it with more information. But it's been really effective, and it's quite safe. They even give it to babies and children and pregnant women. So there aren't really a lot of side effects or contraindications for it.
Thanks.
You're welcome. And that tends to help mostly with like nausea, symptom-wise, like nausea, heartburn, reflux kind of stuff. But it has shown that taken over time and taken regularly can enhance motility. So the next part, the next two parts I think kind of go together, the last two parts, and that's support and coping. And I think this is really important actually, that you surround yourself with positive people who are supportive of your efforts to manage the gastroparesis and implement your comprehensive management plan, who encourage and accept, that you have different needs and limitations and priorities. Obviously groups like this are a fantastic way to do that, where you can actually connect with people who understand exactly what you're going through. Because again, that's part of the whole stress part of this and the stress response, and that's an important piece to get under control. And loneliness is actually one of the most damaging emotions health-wise. It's been shown to be associated with depression and poor outcomes in all kinds of health conditions. So that's why I think support should actually be considered a piece of the management plan, as well as coping skills. Many people have said to me, I've got many emails about this, that really like acceptance has been kind of the turning point for them in their ability to manage gastroparesis. Accepting that they do have it in this moment, they have gastroparesis, and it doesn't mean it's fair or it's good or they like it, but just taking that energy that they may spend being angry about it, or it's not fair, this too, another thing, why this, and directing that energy more towards taking action. Just accepting that for whatever reason, it is what it is, but there are things that you can do to try to make things better. And so a lot of people have said that's really been a turning point for them, and so that's why I share that. That was personally a turning point for me as well. And also, obviously, I think if we don't believe that we have any control over our experience and our symptoms, then we're far less likely to do all of these things that we just talked about. So I think just recognizing that, it is at least to an extent within our control, how we feel on a daily basis, and it's based on the choices that we make, and the decisions that we make, and the actions that we take. So those were the 8 parts, as I see them, of a comprehensive gastroparesis management plan. As I said, if you guys want to start working on your own management plan, you can, on my website, which you have a link down here, there's a worksheet that will help you actually evaluate your current plan, and it may show you, where you're really strong, and then where you maybe need or could use a little bit of help, a little bit of improvement, and then that might actually drastically improve your symptom management. So in conjunction with that, again, you have the code to download the Quick Start Guide to Gastroparesis Management, and that's just like a 40-page ebook that's kind of quick steps to get you implementing these things and make some changes in the way you feel. I think that's it. That's all I have. Are there questions, either about this or just
I have
generally
a
about
question about
gastroparesis?
motility.
Yeah.
Motility problems in the esophagus, does that carry on down? Is it the same thing?
It's not the same thing, but certainly there are people with motility problems throughout various parts of the GI tract. So esophageal motility, there are tests that they do, the esophageal manometry tests, where they actually test how your esophagus contracts. But that's a different diagnosis than gastroparesis.
Right.
Yeah.
Is that I do have?
Yeah, and you're curious too about if you have gastroparesis, right?
Right.
Yeah, and I think I think, and again, not even remotely an expert in mitochondrial disease,
Right.
but I think in the context of an underlying condition that may impact multiple parts of the GI tract, I would think that might be a good reason to get a gastric emptying study.
Absolutely.
Yeah.
That's my next step.
Yeah.
Anybody else?
Did you want to talk a little bit about some of the helpful things that you carry with you, like when you travel, like the Orgain
Sure.
Luna bars and the ginger candies and stuff?
Sure, I can do that. I just finished up, I have a Living Well with Gastroparesis program, and we talk about our GP survival kit. So some of the things that I recommend carrying in there. Jane just gave a lot of really good tips. Orgain, is everybody familiar with Orgain?
No.
Yes? Yeah, okay. It's for the video's sake, it's a nutritional supplement beverage like Ensure or Boost, but it's organic and it doesn't have nearly as much sugar as the Ensure and the Boost. It's about half the amount of sugar.
Tastes a whole lot better.
It tastes,
too.
it
doesn't smell.
it tastes a whole lot better. A lot of people find it settles better. It's not dairy free, so that's the only thing. The Boost and the Ensure are lactose free. The Orgain is not. So that is a problem for some people. But
How do you spell it and why do you use it?
sure, it's Orgain, Orgain, and you would use it to supplement your nutrition, basically. It's a good protein drink, but it's also fortified with a blend of vegetables, fruits. It has some of those fatty acids in it that we were talking about. So it's a really good way to supplement nutrition with the solid food that you're able to get in your diet. And so there are a couple different ways you can use it. Some people will use it as an actual meal replacement. You can use it between meals as a snack. One thing I recommend is if you're having a hard time getting enough calories or nutrition throughout the course of the day, you can just put it in a water bottle and dilute it with water so that it's not real heavy and filling, and just sip on it all day long. And it will give you a couple hundred extra calories and about 15 extra grams of protein and some good nutrition in there. So there are a few different ways you can use it.
Is it thick, like a chocolate and vanilla? I mean, my son's been drinking this stuff since he's been little. And
Yeah.
He's 16 now. I can't not get him to drink anything.
It is.
So.
It's thick. I don't think it's as thick as like Boost and
Okay,
Ensure.
yeah, you won't drink that.
But you can dilute it. Like I did that for a long time when I was pregnant, especially. I sometimes had a hard time with it.
Mhm.
So I would dilute it half and half with water, and it still had flavor and it still tasted good. But it was more like like Yoo-hoo, kind of like a thin chocolate milk.
Okay.
So I don't know if that would work for him. They have strawberry, vanilla, and chocolate. But it's definitely something that most people say is much more tolerable and palatable than the other nutritional supplement drinks.
Is there a non-dairy substitute you would recommend?
Honestly, no, not right now. Orgain is working on a rice-based version,
Okay.
which I'm eager for. My daughter has dairy allergies, so I've had to stop drinking the Orgain as well. But I've seen their preliminary ingredients. They sent it to me, and it's actually not probably going to be GP friendly. They're adding a lot of fiber to it. So I'm still on the hunt for a good GP friendly, dairy free meal replacement drink. If anybody has one, please let me know, and I will certainly make that available if I find one. But that's actually a big problem with a lot of the dairy-free things because they're targeted, towards health-conscious people, and they're high in fiber, and that can be problematic, obviously. So they also tend to be high in FODMAPs. Are you guys familiar with FODMAPs? Yes. All right, I'm going to talk a little bit about that just for the camera's sake because we have some more time. This is another consideration that goes along with dietary management that most people are not told by their doctors. This is becoming more frequently associated with IBS, but it can be really helpful for people with gastric-level carbohydrates. And FODMAP stands for fructooligosahydrolase, a bunch of other kinds of carbohydrates. And they basically are fermented and eaten by the bacteria in your gut. And the bacteria put off gases, and it increases bloating, distension, pain, bowel trouble. And the more I've been talking about this among people with gastroparesis, the more I'm finding that it actually is a significant issue. And that's because much of what we consider GP friendly is actually high FODMAP. So if you were to look at that one-page handout that a lot of us got at the doctor's office, most of the things on it are high in FODMAPs. That includes anything that's wheat-based, even if it's white. So white bread, white pasta, white cereal, white crackers, those are still wheat-based and high FODMAP. Dairy, so any of the skim milk, yogurts, puddings, apples, pears, which tend to be kind of staples for people with gastroparesis, honey, anything with high fructose corn syrup, so that includes a lot of the packaged foods that people are eating. So when you start looking at the list, it's almost startling how many of those things are regular staples on a GP-friendly diet. And when you remove them, sometimes you do notice a significant improvement, especially in those symptoms of bloating, pain, gas, belching, and bowel troubles. So that's something to be aware of. And there's a lot of information about that now. Increasingly, there's more information about that online. I have a Q&A on my website with a dietitian who specializes in FODMAPs. And so her and I recorded a Q&A talking about gastroparesis and FODMAPs. So that's something you can download for free on my website if you need more info about that. And it's also in the Quick Start Guide. Anything else?
Could you go back to the doctor situation? When you start out, you're thinking it might be gastroparesis. You get scoped all the time, and scope might say, "Oh, gastritis," or "Can't see anything." You know, there's nothing really wrong. So then the next time you get sick, they do another scope, and you have the same. What should people be looking for in a GI specialist?
That's a really good question. There are gastroenterologists who specialize in disorders like gastroparesis and motility specialists. Unfortunately, they are very few and far between, and there are none in Western New York.
Exactly.
I mean, with all the fantastic medical facilities that we have here, we have no motility specialists. And I will tell you that that has actually been a significant problem for me personally. I don't see a doctor in New York State. My doctor previously was at the Mayo Clinic in Minnesota and now is at Dartmouth-Hitchcock in New Hampshire. So, you know, there's a little bit of a balance there because for many people you need to have someone locally. But I think the most important thing, you're not always going to find somebody with a great deal of knowledge in gastroparesis, but I think a really important thing is to feel like they're open to learning with you and they're open to exploring with you. Some doctors are and some doctors are not. And I think just like anything else, it's a relationship. And, you know, unfortunately that can involve a lot of legwork, it can involve a lot of co-pays, it can involve a lot of waiting time and transferring of files, and a lot of frustration. But I think in the long run, that's really important. I do have, on my website, I feel like I keep referring you guys to my website, but on livingwithgastroparesis.com, we do actually have a blog post with a bunch of recommendations from people all around the country. They're not all motility specialists, but they are doctors that other people with gastroparesis have seen and have had good experiences with. So I think that's one good place to start because at least you know they've had one other satisfied patient with gastroparesis.
I think that's helpful because I'm finding that it's not even a consideration for the regular GI.
Yeah.
And that's a concern.
Absolutely, absolutely. It's something that is often overlooked, and it's kind of eventually, you know, years sometimes down the road the diagnosis comes. So I would hope that as we continue to raise awareness about this, it's something that more doctors are aware of, and possibly people themselves are aware of it, so that they can know to ask for that gastric emptying study. But in the meantime, you know, I think the best we can really do is keep looking, and I think the recommendations from other people can be quite helpful.
And it wouldn't be inappropriate to say to your GI specialist that maybe he's adequate, maybe for a regular person, but when you've got these, you know, exceptional issues, could you suggest a gastric emptying study, and then would they recommend one that, is there one that's better than another, or?
Gastric emptying study?
Mm-hmm.
Yeah, the 4-hour gastric emptying study is the best, but not all places offer it. 9 years ago when I had my test done at Strong, they didn't do 4-hour studies. You know, they only did 2-hour studies. So now I think more places are doing 4. But No, I don't think it's inappropriate personally to.
Is that the one where they stick down a sensor?
No, so you may be thinking of the pH probe where they measure your pH over 24 hours with a sensor.
No, I can't remember.
The gastric emptying study, they have you eat a meal that's laced with a radioactive tracer, and then they take pictures over the course of 2 to 4 hours. There is also a smart pill that some places offer, not all.
I had to eat a meal.
Yeah.
They stuck something down my nose, like into my.
That's a 24-hour pH probe.
Yeah,
my
the
son was only 8 hours.
Only 8. Okay, so
So
it
I
was
don't know,
probably a
is it just-
pH probe. I would think if it went down your nose, right, in your esophagus,
Yeah.
down to your stomach. I would guess that was a pH probe. I think they're typically, I've heard them mostly done for 24 hours. I don't know what else that would be, honestly.
I think.
They said it was for
motility,
gastric. Yeah, they
or
said it was for gastric.
I had it done twice, but I was
Really?
younger.
No, I don't.
Yeah.
I
Where
honestly,
did you
I
have it
honestly
done
don't
at?
know.
Mass General, and then.
And then Milwaukee. Yeah,
Oh,
Milwaukee.
Milwaukee.
The other thing that it could have been, some places do temporary stimulators, and they kind of gauge the reaction and see if they work, and they place them nasally. I don't know if it was something like that. No? I'm sorry, I don't know that.
I just want to
really
make
don't
sure
know.
that I'm looking for the right test.
Yeah, I mean.
It was pretty
Because
invasive.
we went to Boston to test the medical center and saw Dr. Alex Flores, who's wonderful. He does motility studies. He's the only doctor on the East Coast that does them. And he does a studies like that. It's like the 24-hour pH probe, but they put the leads down through the nose into the stomach, and there's 8 leads that attach to the stomach and the small intestine. And you're attached to a machine
That's
for
the-
about 10 hours, and it tests the motility of the stomach and the
That's-
intestines.
That's what it was.
Okay.
It's
The
that's a motility study.
Yeah,
Duodenomanometry.
that's
Yeah,
exactly
that's
what it
what
was.
it is. Yeah,
Yeah.
that tells you the actual study of the muscles in the nerves.
Right, how your muscles are actually working.
Yeah,
When
that's
they start to
exactly what it
empty,
was.
Yeah.
if they're coordinated, if they're not coordinated.
That's a, what is the name of it?
That's a very specialized test.
And it's only done on the East Coast.
That's a gastro-duodenal
Motility,
motility
Study,
test.
yeah. Yeah.
Unfortunately, they didn't get the lead in the right place because he had vomited, so he went through the entire test.
Was he put to sleep when they put the leads in? Because usually you're put under when they put the
Yeah.
leads in. So you were asleep,
Yeah.
and then you woke up and vomited. So it dislodged the leads.
Yeah.
They should have gave you enough Reglan to keep you.
And he
Yeah.
Yeah.
it was a disaster.
But Dr. Alex
So-
Flores at Boston is wonderful. He's a GI specialist out there. Wonderful.
He's a pediatric specialist, right?
Yes.
Was that at Mass General?
He was at Tufts, New England.
Okay.
Yeah, he was at the floating, but he just moved to, he's still in Boston, but he just moved, I think, to Mass.
Because we did go to Mass General and it was
Yeah.
a nightmare.
Yeah, he just moved because he was at the floating hospital. Yeah, he's great.
Thank you.
Does he do it else besides gym?
You know what, I'm not sure if I'm not sure what his age
Right.
limit is. My son's 16 now, so he's had the test twice. So I'm not sure what his age limit is, but he's wonderful.
Alright, I will give you guys one more recommendation too, if you
Yeah,
are
it's very
willing
good.
to travel around the Northeast. Dr. Brian Lacey at Dartmouth Hitchcock. He's my motility specialist, and he is fantastic. He's extremely knowledgeable, very compassionate, and he really appreciates empowered patients who are a partner in their
Say his
healthcare
name
planning.
again?
Brian Lacey, Lacy.
What hospitals do you have?
Dartmouth Hitchcock in Lebanon, New Hampshire.
Is it possible to do okay on these motility tests and still have gastroparesis, whether it be like intermittent?
The test is really a snapshot, right, of 4 hours for the most part in time, and gastroparesis is a dynamic condition. So it is possible that you have good days and bad days. It's also possible that, I don't know if you were here when we talked about functional dyspepsia. There's a condition called functional dyspepsia, which is basically gastroparesis-like symptoms in the absence of a delay. And there's actually been some discussion among the motility experts that gastroparesis could be renamed functional dyspepsia with delayed gastric emptying. And then there's functional dyspepsia without delayed gastric emptying, because the symptoms are extremely similar. And they don't know exactly why the symptoms may seem the same in the absence of an actual delay.
Treatment would probably be close to the same then?
The treatment, especially everything other than the medical treatment, the prokinetics usually would be the difference, because if you don't have an actual delay, they probably wouldn't use the medication to speed up the gastric emptying of the stomach. Otherwise, the treatment is often very much the same, and especially the self-care things that we talked about. So, the diet, the nutrition, the stress management, the physical activity, all of that stuff is equally as helpful for functional dyspepsia. And something I don't think I mentioned, but it just triggered my memory, is that symptoms don't always correlate to the delay in gastric emptying. So you can have very severe symptoms with a mild or moderate delay. And there are also people who have fairly mild gastrointestinal symptoms with severe delays in gastric emptying. And really, this tends to happen in people who have diabetes. The biggest indication that they have gastroparesis is their erratic blood sugars, not their GI symptoms. They don't know exactly why the symptoms vary so much from the gastric emptying. There are some thoughts that there are other mechanisms that are causing the symptoms, but that's one thing that we don't know. But I think that's important, because sometimes people will almost be discouraged when they get kind of a mild result on a test, when they know that they have such severe and often unrelenting symptoms.
Would that be considered below normal?
Yeah, so technically the cutoff, unfortunately, it's sometimes a subjective diagnosis. So some doctors will call it functional dyspepsia, and some doctors will call it gastroparesis if it's right at that line. Usually 90% is kind of the line. 90% or less emptied in 4 hours. Yeah, I wanted to make sure I was getting that the right way, but yeah, would be considered gastroparesis. So most doctors would probably say that's a mild delay in gastric emptying. But you could still have severe symptoms with a mild delay.
Can that in itself cause severe nausea and vomiting for a long time, for many years?
Certainly gastroparesis can, yeah. Gastroparesis can cause very severe nausea and vomiting for many people, and it can go on, especially if there's not a good treatment plan in place. I think it's important with any of this, though, to make sure that other conditions obviously have been ruled out, but usually by the time you get to a gastroparesis diagnosis, most other things have been ruled out. So sometimes we consider things like cyclical vomiting syndrome, CVS, which is another similar functional disorder that can cause vomiting that has more of like remissions. It'll go away completely and then come back and be very severe and then go away completely. But kind of the constant nausea and vomiting, I think, is typically seen more with gastroparesis.
Mention your books.
Yes, I have written 2 books, Living Well with Gastroparesis and Eating for Gastroparesis. They're both on Amazon. Eating for Gastroparesis is pretty much what it sounds like. It's all about a GP-friendly diet. And Living Well with Gastroparesis really goes through everything we talked about in depth, every part of the management plan. It's set up as a Q&A, just to make it easy to read and easy to understand. And there are also, I think, like 70 recipes or something in the back that are all GP-friendly. So this came about because I just kept getting the same questions from people over and over, and so I wanted to provide the answers to as many people as possible.
It's extremely helpful.
Thank you.
And you can take it in small doses. I mean, the quick start I have.
Oh, good.
And because I was reading and I couldn't read fast enough, and that kind of slowed me down to do with